Good day, wherever you are. I would encourage you to turn on your camera for a moment, if you can. Um, so this is our last meeting. It's been a great year. I just want all of you to know that for next year's colloquium, we received 298 applications. I'm overwhelmed. The thought of choosing 15 deserving people. But that's how special you have been. And I hope that you got a lot out of it. And I hope that you will use that information um, to broaden not only your own experience, but that of others. And I hope you will stay connected to the IMS. If you're not members yet, hopefully you are or will be. And hopefully, if you have any ability to get to Rio, you will do so. So I'm going to ask you, I guess I just told you to turn your cameras on because I want to see all your smiling faces. Now, if you'll turn your cameras off, and then we'll come back at the end of my talk. Someone else is sharing. Okay, send request. I want to be able to share. Can I share, Marion? Okay, multiples. Let's see if this works. Uh, so I want to share. Okay, that should work. And that should work. That should work. So can everybody see? Let me get rid of this. Everybody see the screen, hopefully. Just
Yes.
nod. We're going still on. Great. Okay. So Nancy, if you will go off camera. So I've entitled this Ultrasound in Midlife Women, whether you do it or you order it. Uh, I say here, since its introduction, maybe when I'm done, I'll ask how many of you have access to ultrasound? And if you have access to it, are you doing it? Do you have to send it out? Do you not have access? But regardless, since its introduction, the vaginal probe has revolutionized healthcare for women, especially midlife women. Prior to the vaginal probe, ultrasound was really a tool in obstetrics. Early equipment had barely enough resolution to do very limited things: anterior versus posterior placenta, vertex versus breech, measure biparietal diameter. And this is actually a picture from one of the first linear array real-time pieces of equipment. This is a fetus at 4.3 centimeters or 11 weeks of gestation. Invariably, somebody said, why did you put the caliper here instead of here? And I will admit, in the early days of ultrasound, there was a fair amount of imagination. In my first book, I coined a phrase, sonomicroscopy, because I would put forth to you that the vaginal probe gives us a degree of image magnification that's as if we're doing ultrasound through a low power microscope. We are seeing things with ultrasound that you could not see with your naked eye if you could hold the structure in your hand at arm's length and squint at it. For instance, this is a 3 millimeter embryo at 45 days from the last menstrual period, in which cardiac pulsations are clearly visible. You would not appreciate cardiac pulsations contained within a 3 millimeter embryo if you could hold this in your hand and squint at it with your naked eye. So if you order transvaginal ultrasounds on patients, or if some of your patients have one done elsewhere, or if you do them yourself, I want you to understand, what should you expect? What's significant? The main uses of transvaginal ultrasound: it can be a first-line non-invasive diagnosis in abnormal uterine bleeding and in postmenopausal bleeding. So, short course in histology. Proliferative endometrium is characterized by abundant mitotic activity. This is a hysterectomy done in the proliferative stage. If we look at the glands, every one of them has mitotic activity. It is mitosing. And if we look at a sonogram of this, we can see on day 8 this trilaminar appearance where there's the central white line is the interface between two sides of endometrium. This is the basalis, this is the functionalis. Progesterone, or in sequential hormone therapy, the use of a progestogen, converts this estrogen-primed endometrial functionalis to a secretory phase. This will appear thick and echogenic on ultrasound. Here's a hysterectomy done in the secretory phase. Look at the way the little glands all line up in a linear fashion. And if you look at this sonographically, you see this fiercely white echogenic central endometrial echo. After the functionalis is shed, that basal endometrium that remains is initially quite thin and has what I described as a pencil line appearance on ultrasound. So here is the day after the menses ends. There's really no endometrium left. And this is the interface between two sides of endometrium. Here's an ovary with some early follicles in it. In menopause, there is no estrogenic stimulation of the functionalis, so the endometrium is atrophic. Atrophic endometrium also will have this thin white line, which is the interface between two sides of atrophic endometrium. Pathology of endometrium 101, okay. Heavy menstrual bleeding is defined as excessive menstrual blood loss greater than 80 cc's per cycle that interferes with a woman's physical, emotional, social well-being and quality of life. Used to call that menorrhagia. Unfortunately, they've gotten rid of those terms. Metrorrhagia was the abnormal bleeding between regular menstrual periods. FIGO has now combined all of this into AUB, abnormal uterine bleeding, and they define that as bleeding from the uterine corpus that is abnormal in volume, regularity, and/or timing. So you've all hopefully seen this palm coin thing that FIGO came up with. Polyp adenomyosis, leiomyoma, malignancy, and hyperplasia. This side, coagulopathy, dysfunctional ovulatory, endometrial, iatrogenic, and not otherwise specified. Well, this nomenclature, I think, is unfortunate. No woman comes in and says, I have AUBL. This is a final diagnosis. So some women do bleed so much and so often that they really can't tell what's what. And our registrars have called that menometrorrhagia. However, sometimes a good menstrual history can give you clues to what pathologies are most likely. For instance, if we're talking about heavy menstrual bleeding, I think the biggest reason is big cavity. In other words, the surface area increases with parity. A woman who's had 3 children, the endometrial surface, it's like the size of a pink Spalding ball instead of a ping pong ball. Certainly adenomyosis, submucous fibroids, polyps that are in synchrony with the cycle, and maybe intramural myomas can also cause heavy menstrual bleeding. So it's heavy bleeding at the right time. Intermenstrual bleeding, well, the most common source is dysfunctional anovulatory bleeding, or what doctors call hormone imbalance, polyps, fibroids, hyperplasia, cancers. You know, when I met with the students before COVID, I would say, do you think cancer causes menorrhagia? Blank stares. Eventually, the first-year resident would say, I guess so. And I'd say, so you think cancer bleeds heavily every 28 days? No. So a good menstrual history can give you clues to what the potential diagnoses may be. So back to palm coin, okay? What we're really talking about with palm coin is structural versus non-structural. And as a clinician, that means to me either operative hysteroscopy for structural versus hormonal management or expectant management, although that's another topic. So realize to our patients, all the blood that comes out of their vagina is their period. But to me, a menses is a bleed preceded 2 weeks before by ovulation or sequential hormone therapy. Furthermore, postmenopausal bleeding is not so easily defined. You know that menopause is the final menstrual period, and it's a retrospective diagnosis. No one knows the bleed they just got is the last one they're ever going to get. So we use no bleeding for 12 months due to a depletion of ovarian follicles. If you measure FSH and estradiol, not that they're notoriously unreliable, but it's merely a snapshot of ovarian function at that time. So when a patient has, let's say, transitioned from contraceptive pills in perimenopause to wanting to know if she's menopausal, she comes off, I test FSH and estradiol. FSH comes back elevated, estradiol is in a menopausal range. I never tell that patient she's menopausal. I say your blood work was in a menopausal range because that's just a snapshot of ovarian function at that time. And many women, depending on their age, 2, 3 months later may get a bleed because they weren't truly totally menopausal. So this erratic function of the ovaries in the late perimenopause often makes it difficult to label bleeding as being definitively postmenopausal. But it may not make any difference because we teach even the students that any postmenopausal bleeding is endometrial cancer until proven otherwise. It has to be evaluated. And at least here and probably worldwide, endometrial assessment to exclude cancer is indicated in women who are over 40 who have abnormal uterine bleeding. So my point is you can use ultrasound as the first step in the evaluation of AUB in all cases, as long as you understand the difference between patients who are cycling versus those who are not. In non-cycling patients, every day is the same. So when in the month you do your ultrasound really is not important. But if patients are cycling, they're premenopausal, they're on sequential hormone therapy, timing is crucial. An ultrasound has to be done at a time when the endometrium will be as thin as it's going to be all month long, just as the bleeding ends. And this would prevent misinterpretation of heterogeneous endometrium later in the cycle as being pathologic, and I'll come back to that. So what about bleeding on hormone therapy? When does that need to be evaluated? Well, if they're on sequential hormone therapy, if you look at them at day 10 or 12 or 18, of course the endometrium is going to be thick. We have made it thick. You're giving estrogen and then you're giving sequential progestogen. You want to do this as soon as possible after the withdrawal bleed. If they're on continuous combined hormone therapy, then it doesn't matter when you do it. But keep in mind, and this is a woman on, and this is true really of any formulation of estrogen with progestogen, in the first 4 4-week intervals, the incidence of any bleeding, staining, or spotting, 21 to 26%. So when I put a woman on continuous combined HT, I say, if you have any bleeding in the first 4 months, don't call me. But look at this, at 1 year, it's still close to 9%. So there will be bleeding on MHT. Very low incidence of cancer or hyperplasia, but there will be bleeding. So I ask here, what's the proper use of transvaginal ultrasound in the clinical evaluation of patients, assuming you were doing it at the right time of the month? And the answer is the high negative predictive value of a thin, distinct echo in patients who are bleeding. Non-bleeding patients are an entirely different story. Also realize from a historical perspective, in the beginning, in these patients with bleeding, a thin echo, when it was less than 4 or 5 millimeters, was shown to exclude significant tissue in postmenopausal women with bleeding. So here's a 64-year-old woman who wakes up, she's bled into her underwear, she comes into my clinic, endometrial echo looks like this, she has no tissue, she can be reassured. Here's another example, postmenopausal bleeding with a thin, distinct endometrial echo. We were the first ones to hypothesize this in 1990 in an observational study, Varner and Granberg in 91, but it needed to validate these small observational studies. And so this was the Nordic trial, 1,168 women with postmenopausal bleeding for an endometrial thickness less than or equal to 4, they had no cancers. Enrico Ferrazzi in Italy, 930 women, less than or equal to 4, 2 cancers, less than or equal to 5, 4 cancers. Barrett Gull, Elizabeth Epstein, Barrett Gull. When you combined all of these, the incidence of cancer for an endometrial echo less than or equal to 4 was said to be 1 in 917. Well, should you even still do endometrial sampling? The false negative rate of a thin, distinct echo is much less than a negative suction piston biopsy, and I'll come back to that. And this paper was interesting. If you do a biopsy in a patient who's got a thin, distinct echo, here they use 5 millimeters, only 82% of the time were they even successful. And if they got into the cavity, only 27% gave a sample adequate for diagnosis. In other words, it's inactive atrophic endometrium. Often they got no tissue. So finally, in 2009, 19 years after the first observational study, American College of OB/GYN said when transvaginal ultrasound is performed for patients with postmenopausal bleeding, and an endometrial thickness less than or equal to 4 is found. Endometrial sampling is not required. That was a change in paradigm. They've updated their data a little bit. They added this study out of China by Wang of 4,300 women, and they now divide it into less than 3, less than 4, and less than 5 millimeters. Chances of cancer, 1 in 383, 1 in 339, and 1 in 239. But it still says for average risk women, the current standard of less than or equal to 4 millimeters as a so-called cutoff, beneath which no further evaluation is necessary, is still acceptable. But understand that for high-risk women, obese, hypertensive, diabetic, history of polycystic ovarian syndrome, or patients who rebleed, then further evaluation in spite of an initial thin ultrasound echo may be warranted. I say here the reliability of blind endometrial sampling has radically changed. Why is there an issue with such sampling? Well, these suction piston biopsy instruments, and the most popular one in the States is Pipelle, are small, cheap, disposable plastic catheters that have an internal piston to generate suction. The Pipelle brand in the States has become so well marketed that our residents have turned it into a verb. They will say, I Pipelled the patient. Just like people will say, I'm going to the Xerox machine, even though they own a Canon copier, or hand me a Kleenex, even though they use a different brand. I got interested in this and went and looked in PubMed. It was first described in 1984 by Cornier. In fact, it was called the Pipelle du Cornier, and it was meant to be part of an infertility workup. But the next paper was widely publicized. A guy named Tom Stovall in the States took 40 women with known carcinoma, did a Pipelle sampling prior to their hysterectomy in clinic. He got cancer in 39 out of 40. Hence, he said the Pipelle was 97.5% accurate. And this was widely publicized. All of the journals, the female patient, contemporary OBGYN, they all said Pipelle, 97.5% accurate because it didn't hurt as much as some of the previous techniques. It rapidly became the standard of care. Guido did a similar study to Stovall, but he had 65 women, not 40. He did his Pipelle under anesthesia in these women with known cancer prior to their hysterectomy. They missed 11 out of 65 cancers. But he did us the favor of opening the uterus afterwards. All the cancers they missed were less than 50% of the surface area, and of 11 tumors and polyps, they missed 5. So in 1995, Guido concludes, Pipelle is excellent for detecting global processes in the endometrium. There's other people who've done the same thing. Larson, using a Z sampler, missed 17% of women with known carcinoma. And Ferry, with a Pipelle, missed almost a third of women with known carcinoma. Well, ACOG then produced a bulletin in July of 2012. It's been reaffirmed many times since. Diagnosis of abnormal bleeding in reproductive aged women. It does state the primary imaging test of the uterus for the evaluation of AUB is transvaginal ultrasound. It says if transvaginal ultrasound images aren't adequate or further evaluation is necessary, then sonohysterography, also called saline infusion sonohysterography, or hysteroscopy, preferably in an office setting, is recommended. A sonohysterogram is where we put a little fluid in to enhance the ultrasound detail of the endometrium. They're some of the easiest transvaginal ultrasounds ever performed. The technical aspects are simple for gynecologists. It's much easier to do this than to even put in an intrauterine device. Slightly more daunting for the radiologists who are not used to finding the cervix and having to cannulate it. Remember, fluid enhances sound transmission. That's why ultrasound is so valuable in obstetrics. The baby is in a bag of water, and that's why we get all those great pictures in obstetrics. So sonohysterogram, or what we call SIS, should be thought of as a subset of transvaginal ultrasound. And when? When the endometrium is not sufficiently thin when it should be, or technical aspects are such that you can't see the endometrium. And those technical aspects may be axial uterus, coexisting fibroids, adenomyosis, previous surgery, anything that doesn't allow you to see well enough. So if we think about perimenopausal women, clearly their bleeding can be dysfunctional or anovulatory, but we start to become concerned about the anatomic pathologies. And so in the past, invasive diagnostic procedures were commonplace. So we published this rather large study on perimenopausal women with abnormal bleeding, and about 35% of them underwent a saline infusion sonohysterogram, and about 30% of the time that was for non-visualization of the endometrium, and 70% or so for a thick endometrium when it shouldn't have been. Some examples of saline infusion. Here's the footprint of the transducer. The uterus is in long axis. The fluid is sonolucent. The endometrium is actually quite thin, done at the right time of the month, but she's got a submucosal fibroid. An excellent candidate for resection, plenty of distance from the back of the fibroid to the serosa. Here's a little more modern clip of a saline infusion showing this retroverted uterus, showing a nice thin endometrium surrounding the fluid that's being instilled. Here's a saline infusion that shows a polyp. Once again, the endometrium is very, very thin, done at the proper time. If you do endometrial sampling on this patient and you just get a piece of the lining, you'd be misled. Or here's another saline infusion where it is symmetrically thickened, but it's thick at a time when it shouldn't be. It measured 5 and 4 millimeters anterior and posterior wall, respectively. And so that's a global process. So in a woman like this, we can do a blind sample and be confident in doing so because this is a global process. I say here that saline infusion is extremely time sensitive. You want to do this on the last day or two of staining or the first 1 to 4 days after the bleeding ends. That's when the endometrium will be as thin as it's going to be all month long. Understand the endometrium is a battle-worn organ. These women have had babies and D&Cs and myomectomies and miscarriages and terminations. The endometrium is not always topographically smooth and homogeneous as it proliferates during the cycle. So this can result in what we've called endometrial moguls. Here's a woman on day 17. We've done a saline infusion. Is this focal hyperplasia? Is this a small polyp? This is what the inside of the endometrium can look like if you do this later in the cycle. Or another example of these, what we call moguls. The endometrium, as it lays down, is not perfectly homogeneous. So I say here, in my opinion, I don't think it's appropriate to do a blind office biopsy procedure, or at least rely on it, unless you have first verified that the endometrial process is indeed global and not focal. I wrote that slide 29 years ago, shortly after Guido's paper. Thus, global process is suitable for blind sampling. In my opinion, focal process should be handled under direct vision. But obviously, in some countries or areas, transvaginal ultrasound may not be feasible or available. And certainly, a clinician can begin with a blind sample as long as they understand its potential shortcomings. So I want to switch gears and talk about there's a huge, not a big, a huge difference between an incidental finding and patients who are bleeding. What have healthcare practitioners heard and done? Well, if less than 4 or 5 millimeters is good, then greater than 4 or 5 millimeters must be bad. But remember, this was all done on women with bleeding. So without any validation, women with a thick endometrium who were not bleeding have been and often still are routinely biopsied. And I wrote this paper quite some time ago, the endometrial echo revisited, have we created a monster? The problem is not with the imaging, it's the interpretation of the imaging. So I want you to consider the following case. This was a 65-year-old woman, 14 years since menopause, in excellent overall health, who was on no medications and presented to an ER in New Jersey, across the river from where I live in New York, with lower abdominal pain. She was afebrile. She had normal labs of blood and urine. The ER doctor ordered a CT scan with a diagnosis of rule-out diverticular disease. The CT came back, quote, totally unremarkable, except region of decreased attenuation centrally located within the uterus, recommend transvaginal ultrasound. In the meantime, she had a rather large bowel movement with total resolution of her symptoms. She gets her transvaginal ultrasound. quote, thickened endometrial echo measuring 11.2 millimeters with some heterogeneous echoes suggests clinical correlation, typical of how the radiologists speak in my country. She's already back to her usual routine of playing tennis 1 to 2 hours a day. She gets referred to her gynecologist who attempts to do a biopsy, endometrial biopsy in the office, but the gynecologist is unable to get into the cavity secondary to a stenotic os. Remember, she's in excellent health. She has no risk factors for endometrial cancer. She's not diabetic, hypertensive, obese. She's Paris. She's had 2 kids, but both by C-section. The last one was 31 years ago. Because of inability to get tissue, she gets referred to another clinician in a teaching institution in the metropolitan area, New York University, my hospital, not me, for a D&C hysteroscopy under anesthesia. Despite using fine lacrimal probes and ultrasound guidance, the cavity was not successfully entered. In fact, it was the impression of the operator that a false channel had been created. She sees GYN oncology in consultation. She undergoes hysterectomy, and her final path report is submucous myoma inactive. So, what's the point of this case? So I was discussing this with a friend of mine who's a GYN oncologist. And I said, wow, it's really interesting. All these clinicians felt so obligated to get a piece of tissue sampling on the basis of what they perceived to be an abnormal finding on an imaging study, and actually an incidental finding at that. He said he probably also would have wanted endometrial tissue sampling. Wow, I was really perplexed. And I said to him, wait. Isn't it the GYN oncology community says that our tamoxifen patients don't need endometrial sampling unless they have bled? And he said, yeah, that's true. I said, well, look, the woman we're talking about is not on tamoxifen, a drug that can produce endometrial cancer in this many women. This woman has never had any bleeding in 14 years. She's never had breast cancer like your tamoxifen patients, and she plays tennis 2 hours a day. I said, why do you feel so obliged to sample her endometrium when you feel that tamoxifen patients should be left alone unless they bleed? And a look of realization slowly came over his face, and he said, I guess I see your point. So the question that you want to ask me is, how common is this thick echo in non-bleeding patients? And when it is present, what does it represent? And there's increasingly a body of data worth reviewing. Parsons was the central rereader on what was known as the Raloxifene Uterine Safety Study. I was the first author. She never published this. These are healthy postmenopausal women with osteoporosis looking to be in a trial. They got a transvaginal ultrasound and a sonohysterogram. 10% of these women had an endometrial polyp. Martine Berlier in Brussels, 550 newly diagnosed postmenopausal breast cancer patients prior to initiating tamoxifen therapy were evaluated. 17% had an endometrial polyp. But this paper by Eva Dreisler, I think, really nailed it. It's a randomly selected Danish population of 169 postmenopausal women who underwent a transvaginal ultrasound and a sonohysterogram. The incidence of asymptomatic polyp, 13%. That's 1 in 8 postmenopausal women who haven't bled will have an endometrial polyp. So the question now is, well, what's the risk of malignancy in one of these polyps if 1 in 8 women has it? Well, Fernandez-Parrott removed 117 polyps in postmenopausal women who hadn't bled. None were malignant, and taught me the importance of distinguishing endometrial cancer with polypoid growth from a cancer that arises in a polyp where the base and the surrounding endometrium need to be benign. But this paper by Enrico Ferrazzi, I think, really nailed it. It was a multi-center trial in Italy. They had 1,152 asymptomatic postmenopausal women. They were diagnosed with a polyp by saline infusion sonohysterography. They underwent hysteroscopic removal. There was 1 cancer in a polyp. There were 3 perforations, 7 cervical tears, 3 false passages. There were 3 other cancers that were in these asymptomatic women that they thought were polyps, but were simply polypoid tissue in a focal area on imaging. And if this doesn't nail it, then this paper by Lev Seiji is more real world. 82 postmenopausal women with an incidental sonographic finding of so-called thick endometrium. They undergo operative hysteroscopy. 82% of these women had an inactive polyp, 7 submucosal myomas like the patient I presented to you, 6 atrophic endometriums, 1 proliferative endometrium, and 1 polyp with simple hyperplasia. No cancer or complex hyperplasia, but almost 4% incidence of serious complications, perforations, difficult intubation. And if that's not good enough, because I don't know if you, but I always have that occasional patient who says, but I'm always the one. This paper by Gerber, ultrasound detection of asymptomatic endometrial cancer in postmenopausal women, offers no prognostic advantage over symptomatic disease discovered by bleeding. What did Gerber do? Found 190 women who had endometrial cancer who bled the way it usually presents. The reason the cure rate is so high, it bleeds early. He found 16 women who had cancer who had not bled. Through 55 months of follow-up, the overall survival and disease-free survival was absolutely the same as long as treatment was undertaken within 8 weeks of the bleeding episode. So when I have a woman with a thick endometrium discovered incidentally, I am sure to tell her, if you have any bleeding, staining, even brown discharge, you must call me. Virtually never do, because if you initiate treatment quickly and they did have cancer, they'll do just as well. And this will spare the other 996 any kind of intervention risks and discomfort who are asymptomatic. So in postmenopausal bleeding, yes, this is cancer until proven otherwise. We talked about the role of the high negative predictive value of a thin, distinct echo. If it's available, you do transvaginal ultrasound first. If you need to go to sonohysterography, that'll help triage the patient to now we see well enough to see there's no pathology. We see a global process, and I do a blind sample or a focal process, which I think needs direct vision. But for an incidental finding of endometrial thickening, there's no validation whatsoever that these patients need automatic endometrial sampling. The incidence of thick echo is probably 10 to 17%, and very much like simple cyst of the postmenopausal ovary was 20 years ago, and I'm going to go over that. But I say here, it's still appropriate and always was to use some clinical judgment. In other words, if you say to me, this woman has a thick endometrium and she has a BMI of 40 and she has diabetes, and I'd like to evaluate her, well, that's good judgment. But to have a number above which you feel women need to be invaded makes no sense whatsoever. Some other issues with incidental findings on GYN ultrasound. What about these ovarian cysts? The word cyst is scary to patients. They want it out before it becomes cancer. I've finally gotten our trainees to lose the word cyst. When they present a gynecologic history now, they say no history of pathologic cysts. Functional cystic changes versus neoplastic. Understand that a dominant follicle is a cyst. Gets to be about 2.5 centimeters before it ruptures ovulation. If it doesn't burst and grows, it now becomes a follicular cyst rather than a cystic follicle. And after ovulation, bleeding into the corpus luteum can produce a hemorrhagic cyst. And they look pretty ugly on transvaginal ultrasound, and they produce pain. So here's a fresh corpus luteum contained within an ovary. The crinkled, crenated, looks a little like Batman's cape. Here's a rather large hemorrhagic corpus luteum cyst. This is all blood, clot, and fibrin. When first introduced, ultrasound showed these cystic changes so easily, people and many postmenopausal women were operated on. This is an example of a postmenopausal cystic mass, unilocular cystic structure. There's through transmission of the posterior wall. Here's another postmenopausal ovary with a small cystic structure. In 1986, this was the first paper published on that topic. This came out of Harvard. 13 patients with a sonographically detected simple ovarian cyst, one of which supposedly had a borderline tumor. So the authors recommended immediate surgery. And through much of the 80s into the 90s, postmenopausal women with a cystic mass like this was operated on routinely. In 1989, we published this paper, The Postmenopausal Cystic Adnexal Mass, the potential role of ultrasound in conservative management. We had 26 surgical specimens, none of which had malignancy or borderline. We concluded that small, we use less than 5 centimeter, unilocular, unilateral, postmenopausal, adnexal cystic masses with no septations or ascites would have a very low incidence of malignant disease. So we said, therefore, serial ultrasound follow-up without surgical intervention may play a role in clinical management. We were very timid because the standard of care there was surgery. By 1992, Barbara Gosink and Debbie Levine had scanned 184 asymptomatic women. 17% had a simple adnexal cyst. 1998, Bailey scans over 7,700 women. Only 3% had adnexal masses. About half resolved in 60 days and half persisted, but many of these may have just been perimenopausal because they were just over 50. They didn't have labs showing they were menopausal. 45 women got operated on, no malignancies, 32 cystadenomas. So about 2/3 of these cystic masses were cystadenomas. We went back and looked at our 26, and about 2/3 of ours were cystadenomas. By what year is this? 2003, as part of the ovarian cancer screening program at the University of Kentucky, over 15,000 women were scanned. 18% had a unilocular cyst. So the crucial take-home message here, unlike cervix with its dysplasia, breast with ductal carcinoma in situ, lobular carcinoma in situ, endometrium with its hyperplasias, where as a clinician, I feel like I spend much of my day looking for these pre-cancers before they cross the line and become malignant. There is no evidence whatsoever that this is true in epithelial ovarian cancer. In other words, benign cystadenomas do not become cystadenocarcinomas. Crucial fact. Because if they did, we'd have to remove all of these simple cystic structures since consistently 2/3 of them are benign cystadenomas. So finally, in 2009, the Society of Radiologists in Ultrasound had a consensus panel in Chicago. 14 people met for a day and a half. I was one of them. The panel concluded cysts that were less than 1 centimeter didn't even need to be reported. Between 1 and 7 centimeters, you should say they're almost certainly benign. Yearly follow-up, at least initially, was recommended. And then they said if it was greater than 7, it may be difficult to assess completely with ultrasound. And therefore, surgical exploration or further imaging should be considered. Recognize 7 of these 14 people were radiologists. They felt they couldn't evaluate the entire cyst wall. Now with 3D, that's no longer true. And finally, ACOG in 2016 was saying, with rare exceptions, simple cysts up to 10 centimeters. And transvaginal ultrasound performed by experienced ultrasonographers are likely benign and may be safely monitored using repeat imaging without surgical intervention, even in postmenopausal patients. Many of you are familiar with IOTA, the International Ovarian Tumor Analysis. There's a method developed in Europe to classify adnexal masses based on some standardized ultrasound terminology. I'm certainly hopeful that through the expansion of IOTA, perhaps a thing in the States called ORADS, or IOTA now has the ADNEX model, that this may change our approach, but in my opinion, not quickly enough. I want to talk a little bit about endometrial fluid collections in postmenopausal women. In the 1980s, endometrial fluid, and this was on transabdominal ultrasound, was felt to be an ominous sign, very highly associated with malignancy, 75%. So I wrote this paper, Postmenopausal Endometrial Fluid Collections Revisited. Look at the donut rather than the hole. And the editor of the Green Journal said, I like this paper, but are you sure you want it referenced for keywords donut and hole? And I said, if you can think of a better way to express it, because this was before we were doing saline infusion sonohysterogram. I had 9 patients where they had endometrial fluid, and I struggled to get tissue sampling. I got it in 8, and all 8 were inactive. I thought 75% chance of cancer. I have 8 in a row that are inactive. I have to be the luckiest doctor in the planet. Till the 10th patient came in. She looked like this. Here's the endometrial fluid. Here's the tissue surrounding the fluid. I realized, and this turned out to be complex hyperplasia. She had cervical stenosis, which is why this fluid collects. Went back and looked at the original 9, and they all look like this. So I realized it's not the fluid, it's the tissue surrounding the fluid, the donut, not the hole. And so a more modern clip. And the number of women postmenopausally, depending on how distantly menopausal, who will have a little bit of endometrial fluid, approaches high single digits, 7, 8, 9% of patients will exhibit endometrial fluid, but it's a naturally occurring sonohystogram. You see the thin endometrium surrounding the fluid. Another example of a endometrial fluid collection. Here's a woman with a type 0 myoma and its acoustic shadowing, very thin atrophic endometrium surrounding the fluid. Adenomyosis. We define this as the presence of endometrial glands and stroma ectopically located in the myometrium, and it results in hypertrophy of the myometrium and enlargement of the uterine corpus. The incidence depends on how hard you look for it. There's publications that show when you do 3 routine sections of the myometrium in a benign uterus, it was present in 31% of cases, but when they did 6 sections, it was present in 61% of cases. Yes, it can result in pain and bleeding, but sometimes it can also be asymptomatic. So here's an example, glands and stroma located within the myometrium. Here's the surface endometrium, higher power view. Sonographically, it's pretty easy to diagnose. You get asymmetric uterine wall enlargement in the absence of fibroids. You get these hyper and hypoechoic areas. You get these small cystic spaces, linear striations instead of the circular pattern on color Doppler that you get with fibroids. Here's an example of adenomyosis. The posterior myometrium is triple the size of the anterior myometrium. This is a different view of the same patient. Here's another patient with adenomyosis. You can't see an endometrial echo. You see all of this mottled area. This is all adenomyotic. Here's another patient with adenomyosis, thickened anterior portion and all of these sonolucencies contained within the myometrium. Same case. So the problem is the prevalence of adenomyosis is very, very high. My sonomicroscope can identify lesions very, very easily. What I've seen happen is sometimes patients are labeled with a disease who are asymptomatic. So the 42-year-old comes in, you think you feel a mass of the ovary, an ultrasound is obtained. There's no mass on the ovary, but there's clear evidence of adenomyosis. She's asymptomatic. 3 years later, she starts bleeding twice a month and heavily because she has dysfunctional anovulatory bleeding of perimenopause. The clinician says, oh, you got adenomyosis, you've got bleeding twice a month, and she ends up with a hysterectomy, even though it's true, and not necessarily causal. Oma comes from the ancient Greek. It's a suffix meaning tumor or other abnormal growth. It's often attached to a body part. An incidental oma is a radiologic neologism found incidentally and of dubious clinical significance. I have a cyst in my kidney, one in my liver, and a benign hamartoma in the right lower lobe of my lung, none of which were discovered because I was having any kind of problem, but I was having imaging studies for other reasons. I want to play you this video.
Days of the stethoscope are gone. So it's been a good run. It's been a good run, stethoscope, but it's time for you to retire because there's a new kid on the block, and that is this. This is the Butterfly IQ diagnostic ultrasound. And this little device is going to change the way that medicine is practiced. It already is changing the way that medicine is practiced. This is going to replace the stethoscope. This little device plugs into my iPhone. And with it, I can instantly look at a patient's interior without radiation, without any big fuss. I can scan their neck and I can look directly at their carotid artery. I can see how much blood flow there is in there, if there's any blockages, how much calcification exists. I can look at their gallbladder and see if they have any stones. I can check the meniscus of their knee while they move their knee, and I can see if the meniscus is injured. I mean, the days of...
So, pretty cool? No, dangerous. But will he have to reinvent the wheel? For instance, what percent of men over 50 who are totally asymptomatic may have an old tear of their meniscus? I already introduced this term incidentalloma. I already told you I got a cyst in my kidney, my liver, and the hamartoma in my lung. Last year, when I gave a similar talk to the colloquium, and I discussed these issues of incidental finding, simple postmenopausal cysts, asymptomatic endometrial thickening, this woman from Ireland, in that group, she said, oh, we call that vomit. Vomit, yeah, victim of modern imaging technology. Okay. So my take-home message, ultrasound is a wonderful non-invasive tool to see things previously not seen. However, we must understand what constitutes normal. In other words, what's the background noise before we act on findings that may be much more common and clinically inconsequential. Remember, we said 13% of postmenopausal women have a polyp. As much as 17% postmenopausal women will have a simple cyst. So in summary, transvaginal ultrasound is a low power microscope. It's increasingly utilized. Many patients understand the limitations of the traditional bimanual exam, and at least in the States are asking, if not demanding, a vaginal sonogram. As I mentioned, 13% of women have a polyp. If asymptomatic, the risk of malignancy is ridiculously low. In the Italian study, 4 in 1,100. 6 to 18% have a benign cyst with no malignant potential. Hopefully, this will help your patients to use transvaginal ultrasound properly. The most important thing is to reduce unnecessary surgery, further testing, and anxiety because of things much more common and less ominous than previously appreciated. And I thank you for your attention. And I say, let's put your pictures back up. And we've got plenty of time for some discussion, questions. I'd like to see, put your pictures up. You can just, how many of you do not have the ability to get a transvaginal ultrasound ever? Anybody? Does that not exist in your, that's nice to see. How many of you have to send an ultrasound out to get it done somewhere else as opposed to in your office? See one hand, okay, 2 hands, 3 hands. How many of you have the capability of doing a transvaginal ultrasound yourself on your own patient? Excellent. See, what I tell you is, in the States, and I think in Australia, not sure anywhere else, maybe Canada, you'll help me, this concept of a sonographer. And let me tell you, sonographers are great. They're very well trained, but some of them know more than the doctor they work with. Doing an exam takes 70 still images, and then 2 hours later, the radiologist comes by and reads it off a computer screen. Or increasingly, they use teleradiology, because it's cheaper. The images are sent to India to be read by an Indian radiologist who charges much, much less to the big health system in the US. This is problematic. One of the things that I have talked about is, and it's not doublespeak, there's a difference between an ultrasound examination and examining your patient with ultrasound. What I had said years ago was the basic bimanual exam consists of 2 components. There's an objective component and a subjective component. The objective component is this uterus normal size? Is it enlarged? Is it irregular in shape? Is this ovary normal size? Is it enlarged? That's objective information. You can replace that with an image if you are capable of it. The subjective, is there tenderness? Is there normal mobility? This depends on the experience and nuance of the examiner, and that is not usually replaced with a still image. I've changed my thinking, at least in the States. It's not a problem if you're doing your own scan. I was always talking about, I wanted to use imaging as part of the physical exam. Well, now I want the imager to examine the patient. In other words, many of the sonographers simply take 70 images, but use your left hand on the abdomen, use the probe pushing in and out. Do you elicit pain? Is there normal mobility? You can do this as part of an ultrasound examination. It's not simply the images and the anatomy that gets produced. The American Institute of Ultrasound and Medicine and a bunch of other societies got together. They have parameters for the performance of transvaginal ultrasound. They have something like 19 different indications. The number one indication, at least, and they're not in any particular order, is pelvic pain. Well, how do you associate pelvic pain with a still image? I mean, yeah, if a woman's got a typical endometrioma or typical hydrosalpinx, you can surmise that her pain is due to endometriosis or scar tissue. But if you don't do a dynamic scan, if you don't push with the probe and see if you can elicit that pain, there's so much more information that you can glean from ultrasound if you have the capability of doing it yourself, which more than half of you raised your hand and you do. So, I mean, I've learned so much from my colleagues worldwide, who the system in many of your countries is much better than the system here. So questions or your experiences or your concerns. Yes, Dana, unmute.
Hello. I'd like to start quickly by thanking the IMS really for giving me this opportunity. It's been an amazing journey. I've actually started recommending it. And actually, I really enjoyed your lecture. It's so practical, really. It's what we're experiencing day to day. So thank you. I really, really enjoyed this presentation. So I have a comment and I also have a question. So yes, I came from the UK before moving to Qatar, where it was really difficult to get a scan done yourself, actually. Our training was limited, actually, during residency because all the sonographers wanted to do the scan. So they'd hide the vaginal probe, only they would do it. But, because it was all taken up by radiology. But as time has gone on, actually, I actually think a transvaginal scan can be useful. It could be the third arm of a gynecologist in the right setting. So now I do it more and more. And you do find incidental findings a lot. And we should really take the clinical picture into consideration in the examination. But what I found now that I run a dedicated menopause clinic is often you'd start these women on HRT and varying doses, and you're basing it on symptoms, etc. And when they come back with irregular bleeding, you try and leave them 3 months and 4 months without investigating. Obviously, you get a little bit twitchy because they're postmenopausal. They come back, you scan them, and there's a large big polyp there, or a submucous fibroid or something. And then sometimes I think, oh, damn, I wish I'd done a scan before I started on HRT. So I started picking up more and more of these, and then I do a hysteroscopy to remove the polyp because they want to stay on HRT and they can't get irregular bleeding. So then I started doing more scans before starting them on HRT, and then I was picking up these incidental findings. So it's a tricky kind of, a tricky situation. Sometimes do I do a baseline scan, at least just to see exclude a polyp, or if there is a small one, I can maybe counsel them and say, look, estrogen can increase the polyp growing, risk of bleeding from it, and similarly with a fibroid. So that's where I'm a little bit in between. Do I or do I not do a baseline before starting HRT?
There's a great questions, comments, and I can address that, at least what I do, if you have that capability. I do like to see a thin endometrial echo at the beginning of starting, MHT as they want me to now call it. But I said that the public is so enamored of HRT, that's an uphill battle. The analogy I give is my first book was called Endovaginal Ultrasound. You can see where that ended up as transvaginal ultrasound. So the goal to call it MHT instead of HRT, if you look on Instagram, that train's left the station. So I'm going to use HRT, even though friends of mine get mad at me because I still use it. I like to see a thin endometrial echo. If there's a thin endometrial echo, then if there's bleeding, as I said, I'm comfortable they haven't developed anything and that they're going to be one of that 21 to 26%. My advice would be if I see like a polyp, I still don't think I would remove the polyp prior to starting it. If they bleed then I'd remove the polyp. If they have a polyp and they never bleed, then 17% of people are going to be like that. And if they don't bleed, then there was no need to remove that polyp. We've already established that these menopausal patients with a polyp have such a low incidence of malignancy. If you're taking those polyps out, it's to prevent any of the bleeding, which is going to be pretty common anyway. So my advice would be, yes, they've got a polyp, but if they never bleed, don't worry about it. And if they do bleed, then I think I would take them out. And I think you will end up taking out a lot less of these asymptomatic polyps. But I do get a transvaginal ultrasound on patients before I start MHT or HRT. I have that ability. I'm one of the few people. I mean, I have the know-how. I'll give you an interesting, for instance. So for the scientific program for Rio, I'm the vice chair of the scientific program. And they said, we'd like to have a debate, perhaps, that all postmenopausal women should have a transvaginal ultrasound. And they assumed I would be the pro, the yes, because I do that. I said, well, I don't know if that's such a good idea, and I would actually be the negative. I said, it may sound hypocritical. I do it, and I'm saying don't do it, because if everybody, at least in the States, were sent for a transvaginal ultrasound routinely, the number of MRIs and unnecessary surgery would go through the roof. Because until or unless you educate people about these common incidental findings, I like to say I spent the first half of my career teaching people how to do transvaginal ultrasound. I spent the second half teaching people how to sit on their hands because the number of incidental findings. So you must understand the difference between ominous and innocuous and common. So, it seems paradoxical, but until or unless we train people to be as knowledgeable about these incidental findings, if we turned everybody loose on every patient, we're going to increase anxiety, increase interventions, unnecessarily. Other comments or questions, other people's experiences with ultrasound. The other, okay, go ahead. Sure, Gina. Unmute.
Thank you. I'm at first also very thankful for all knowledge I have got in this in this lecture and other lectures. And you have answered of my questions about asymptomatic polyps in women with on menopause, on hormonal therapy. But I would like to ask about hydrosonography. Maybe is it useful to perform not only ultrasound to measure endometrium, but perform hydrosonography before starting menopausal therapy?
So
Like
hydrosonography
in women
is her
on
term,
tamoxifen.
it's her term for saline infusion.
Yes.
The only indication for saline infusion in my hands is if I can't see well enough, and I didn't spend enough time, perhaps. That's going to be true in a lot of menopausal women, either from previous surgery or fibroids or adenomyosis or the axial uterus. The closer to a right angle the beam of sound is to the structure, the better you're going to see. So anteverted or retroverted uterus, you see very well. In axial uterus, you don't always see the endometrium that well. So if you feel you need to see the endometrium, you'll put saline in. I don't routinely do that. I like to see a thin echo before I start, but if I cannot see it for technical reasons, I don't subject the patient to the discomfort and, in this country, some expense of a hydrosonography, as you call it. I don't feel there's enough of an indication. But if you, for whatever reason, she's obese or you're concerned, if you feel the need to see it and you can't see it without saline enhancement, then go ahead and put some saline or gel in. No question. Another thing that I didn't touch upon that I should mention is the liberal use of color Doppler as morphology. There were some very early papers. A guy named Asim Kuryak out of Croatia claimed that if the resistive index, because you can measure resistive and pulsatility index with Doppler, was less than 0.4, that was very indicative of malignancy. Well, then he was found out to be not very honest, and his work was never repeated. But color as morphology, and what I mean by that is the late Beryl Benacerraf, a very good friend of mine, a radiologist at Harvard, who was one of the top sonographers in the States, and I wrote a book with her. She, and I still have it somewhere, I should include it in this talk. She showed a picture of two ovarian masses, which were both kind of ugly, you know, septated and had a lot going on. They weren't simple cysts. They could have been mirror images of each other. The next slide, she pushes a button. The one on the right totally lights up, color score like 4. The one on the left, unchanged, absolutely no blood flow. And she had like a throwaway line, which I've used many times. No color, no cancer. Tumors need blood to grow, to divide, to invade. Things that are totally avascular, assuming you've got the right settings on your equipment, are never malignant. Now, that doesn't mean that when things are vascular, that they are malignant, but the lack of vascularity is a very, very reassuring sign in my hands. Something else that's worth noting. Other comments or questions? Well, if not, going once, going twice. Listen, you've been a great group. Oh, wait, I see. Who put their hand up? Somebody did, or was that a mistake?
Yeah.
Oh, yeah.
Maria.
Go ahead.
Is there an absolute cutoff, like not talking about polyps, but a generalized thickening of the endometrium, which might be considered a cutoff before in an asymptomatic
Right.
menopausal?
And so I probably wasn't clear enough. Okay. I hear this all the time. Oh my God, 19, 20, 25 millimeters. I mean, there's got to be a number at which you start to get nervous. I will tell you in my experience, and this is not published, the very thickest endometria tend to be inactive polyps and simple hyperplasia. Cancer tends to bleed early unless there's cervical stenosis. So there's really no number above which I think they need to be invaded. I think you're much better off if you want to individualize at looking at individual risk factors, potential risk factors, but thickness itself, it's not like thicker is worse. As I said, most cancers will bleed relatively early. Look at those early observational studies. We had one cancer, she bled at 7. Varner had a cancer at 5 and at 9. Granberg had a cancer at like 8. The cancers tend to bleed early. So you see an asymptomatic, very, very thick. Now the other thing is educating people. The membership in what used to be NAMS, which is now the Menopause Society, when I was president, hovered at around 2,000 for years. This year, it surpassed 12,000 people. Everybody wants to be a menopause doctor. It has come out of the closet. If I was at a cocktail party 12 years ago, and I said I was president of the Menopause Society and speaking to 3 women, it cleared the room. They associated that with old. They associated that with wrinkled. They didn't want to hear it. It was a dirty word. Now it's all over Instagram. It's the biggest thing that you can imagine. Everybody wants to be a menopause doctor. And so it's a little bit scary about what is being transpired there, and what women are being told. So we need to be, I think, very careful about how we approach that. I hope that kind of answers your question, but the individualization is crucial. So many of these new people are, they have one arrow in their quiver. I was in a debate in Melbourne. Should all MHT be transdermal? People believe that it's less thrombogenic, and therefore they put everybody on a patch. There are certain advantages to oral estrogen, especially conjugated equine estrogen, if you have that available in your country. That's been shown in hysterectomized women to reduce breast cancer and reduce breast cancer risk and mortality. It's got some SERM-like properties of its own. Also, oral estrogen will lower cholesterol approximately 20%. Transdermal doesn't. It has more favorable effects on glucose metabolism. If a patient's at risk for thrombotic event, sure, I use transdermal, but I don't use it on every single patient. And these newcomers are putting everybody on, transdermal and progesterone, regardless of their risk factors, which really is sort of inappropriate to only have one thing that you use. So I hope that Claire will send out some sort of evaluation. It would be very helpful if you do receive something from Claire to hear back from you guys about, your experience. And you don't have to just be total. I mean, if it was great, then tell us it was great. But what were the good talks? What talks were not as helpful? What you'd like to hear, or, in trying to improve this each year, it's really important to get the feedback, and I expect many of you to be the future leaders of the IMS long after I'm gone. One day, I'd love to see one of you be running this thing, decade from now or more. Okay. So you have a responsibility to the field. All right. It's been a pleasure, and I hope I get to meet some of you in person if you can make it to Rio. All right. It's 9 minutes past the hour, and I have patients waiting already. So thanks a lot. Been a great year. Thank you very much.